stimulation, you get the ice pick out and off you go. Now we'll see if this works. So what happens is you start off getting the ice pick, and what you really want is for this to happen. So this is fibre cartilage. You get a probe, you press it, it looks like cartilage, feels about as spongy as cartilage, and those sorts of lesions do well. Now, I reckon this is going to work. No, okay, we don't have video, that's okay. That's a shame. Yeah, no, I did that. Did you have it embedded in your thing, or how did you get your video working? That would have worked too. That's all right. Particularly want to see the operative videos, you can tell me. I'll play them all at the end off the actual file itself. So there was just some operative videos on cleaning out the edge of the lesion, making sure you take it back to stable cartilage around the edges, and then drilling some holes into it. Right, so once you've done this microfracturing bit, what happens if the results deteriorate over time? There's a couple of studies on repeat debridement for failed previous debridement. Initially they were actually successful for a long period of time. And both of these studies have shown fairly good results. So if you get a couple of years out of it and they come back, you can legitimately debride it again and they do okay. Not quite as good as the primary series, but not bad. Then we've got the hyaline cartilage generating ones. So there's OATS, osteoarticular transfer system, where you take little cores of bone and cartilage plugs out from usually the knee, non-weight bearing area, and Talus has also been described from the side, although I don't know anyone that does that, and then you've got to put them into the area. I find this, I've only done this a couple of times, I find it quite hard, very hard to get the surface even. There's all the problems with donor site morbidity and knee pain and things like that occur. But if you actually just look at their ankle symptoms, 87% of them, so very good results if you just isolate the ankle symptoms alone, but it doesn't account for the donor site problem. So we've come up with newer systems. So the other hyaline cartilage generating thing is chondrocyte grafting, or matrix chondrocyte grafting. Is obviously a knee rather than Talus with the old periosteal patch that took an hour or so in. And there is no difference in any of the literature to suggest that doing it with a periosteal patch, so AC, is better than the newer versions where they get impregnated onto collagen patches called MACI. Okay. But the results, as you can see, 76%, not as good. Not quite as good yet as drilling and things like that. Obviously requires two procedures, one to get the cartilage cells, send them off to the lab, grow them up, put them back. And you can actually take, whereas unlike the osteoarticular ones, you can take it from the knee, but usually there's enough cartilage around the edge of the talus or the edge of the lesion to actually have enough cells in it to grow. So you don't necessarily have to violate another normal joint. So there's a few of these that are written up. Tim Schneider did a bunch of these with osteotomies, almost largely medial malleolar osteotomies, so medial lesions, and they did pretty good. Okay. Hardesty over in Perth did all of these open, and as I said, 70–80% were pretty good. The over 40s did poorer. So we wrote up a series of arthroscopic ones with 20 patients. 90% said that they had improved. That's probably a little bit flattering. They had actually improved on their objective scoring, but some of them not much. But probably 80% of them said they'd have it done again. But it is a pretty big deal to do it. So you can pretend there's another video there. So what do I do in the face of all of that? The Zengerink's actual recommendation is, because of the relatively high cost of this procedure, it's roughly 10 grand, and the knee morbidity with OATS, they think that bone marrow stimulation is the treatment of choice. So debridement, drilling is a bone marrow of choice, is a treatment of choice for the primary lesions. Sometimes it is better to go back to what you know, and you know what works. But then sometimes you need to think about new things as well. As you're lying back thinking about stuff, other ideas come to you. So now the companies are prepared when you go in, particularly for the larger lesions. And if I see a surprise larger lesion, one of the companies has an unplanned biopsy kit to save you a second operation. You can actually, when you're debriding the edges and about to do the bone marrow, drilling or burring, whatever it is you do, then they'll put it in a jar and keep it in the freezer for up to 18 months so that you don't have to come back and find more graft later. And then if you do need it, if they've failed their drilling, you can go back and do that then. Good. This is a big deal though. The rehabilitation starts with telling them that it's a big deal. They're in a cast for 2 weeks, non-weight bearing for 6 weeks, further 6 weeks of partial weight bearing. So 3 months before they're fully weight bearing. If it works, it usually gets rid of their bad pain first off, and it's usually probably because you've actually addressed the edema. But by the time you're running and swimming and cycling 6 months, this is double the rehab time and twice the number of operations it's drilling. So it is not trivial.